Hi, this is Darcy Gaydon recording PowerPoint audio for the Integumentary system. As you may know, the largest organ of our body is our skin, and it is indispensable for human life. We have three layers of the skin. We have the epidermis, which is the outermost layer, the protective layer that is approximately 0.1 to 1 millimeter thick, so very, very thin, but does provide us sound protection. And then the dermis is in the middle, and then the subcutaneous tissue or fat is the third layer. The dermis is the largest portion of the skin, approximately 5 millimeters thick, and this is where we contain a lot of our blood vessels and nerve fibers. We're not going to talk too much about the appendages when we cover the skin unit here, but we obviously have hair, nails, sweat glands, and we will talk about them as they come up with different diseases. This slide is just further explaining the layers of the skin that we have talked about already briefly, but the epidermis is the external barrier. We contain a lot of protein that acts as a barrier. There's immune protection that repels pathogens and protects from invading bacteria, and we also have keratin on our skin, in that first skin layer. The epidermis almost completely replaces itself every 3 to 4 weeks. We also have the melanin that protects us from the UV rays. Certainly this isn't us not needing to use sunscreen, but we do have melanin that is stored in the epidermis that will give us some protection, and that also allows us to tan or get our skin color. And then a very large function of the epidermis is that it helps us to maintain our hydration status. So if we have any open areas on the epidermis, we lose a lot of fluid through that area. The dermis then is our true skin. Excuse me. And again, I said this was the largest portion of the skin. The biggest function of the dermis is that it regulates our body temperature, and it also conducts messages to the central nervous system as far as a protective mechanism, really, so that if we are touching something that's hot or cold, our skin will sense that, and it'll send that message to our brain. So regulates body temperature, very important, and also that transmitting of messages. When we get to talking about burns and we talk about the different first, second, and third degree burns, when we have patients that have very severe, deep second degree burns and third degree burns where they have basically burnt all of that dermal layer, we've also killed all of those nerve endings in that area. And so those patients, while we think, oh, it's a very severe burn, they're going to have a lot of pain, those particular patients with the third degree and deep second degree burns will not have pain initially. As the nerve generation happens throughout months to that first year, they have more of a delayed pain that comes when they are healing. The subcutaneous tissue provides cushion between our skin layers, muscles, and bones. This picture is in your textbook, and again, it's just showing you the three layers: the epidermis, that very thin top layer, the dermis, which is our true skin and our largest portion. You can see the sweat glands and hair follicles and things go into there, and then all of our nerve endings and everything are in that area. So again, once we talk about those deeper burns that are killing because of the burn injury, those areas, they may not have pain, and then the subcutaneous layer on the bottom. So let's talk a little bit more in depth of the functions of the skin. Protection is obvious. Although the epidermis is only 1 millimeter thick, it is very effective protection. We also have thickened skin on the palms and soles, the palms of our hands and the soles of our feet, which makes sense. We have constant trauma or usage of those areas, so we do need a thicker and better protection. Sensation, we do have those nerve endings in the skin that allow us to sense temperature. Again, in the dermal area, it's sending messages to the central nervous system. And we do also have more nerve endings in our fingers, which again would make sense, so that if we are touching something sharp or have pain, or would know to have pain, so that we remove our hand from that, and definitely cold and hot senses temperature as well. As far as the fluid balance, which layer helps with this function? That is the epidermis. So the outermost layer, or the epidermis, it has the capacity to absorb water. So therefore it prevents excessive water and electrolyte loss. And we know that we normally lose approximately 600 milliliters a day via evaporation or sweat. So we do lose that 600 mils a day, but that epidermis prevents us from losing more than that. So again, one of the major complications with severe burn injuries is fluid loss once those areas are no longer intact. Temperature regulation, as we mentioned before, is primarily regulated by the dermis. Our body continuously produces heat as a result of metabolism of food, which produces that energy source. So we definitely need temperature regulation. We can lose heat through radiation, conduction, convection. Those are all ways that we can lose heat. But as we think about the skin, it is very, very important to understand the concepts of vasodilation and vasoconstriction. So let's start with vasoconstriction, because I think everybody really knows that pretty well. So if we have decreased skin blood flow or vasoconstriction to the skin, that produces that pale, coolness that we've talked about with like cardiovascular disease and such. So the body will respond, again, if there's decreased blood flow to the skin, which we will see with vasoconstriction, it will try to help to conserve body heat. As far as vasodilation, that is just when we have the increased blood flow to the skin that results in more heat being delivered to the skin, which is why we see that red hue. And then the body will have a greater rate of heat loss. So again, if we think of a cold day, our blood vessels and skin constrict, therefore decreasing heat loss from the body. So this picture really shows this phenomenon, the last slide that we just talked about, and I forgot to mention the last function, so I can just talk about them quickly. But on the last slide, the vitamin production, this basically has to do with the skin being exposed to ultraviolet light. That helps us convert substances necessary for making vitamin D, and we need vitamin D for absorption of calcium. So we know that sunlight and that vitamin D exposure is helpful, and then we will also get to obviously protecting from skin cancer and melanoma as far as skin protection that way. And then the immune response function on the last slide, this is just to reinforce that we do on our epidermal portion of the skin, we do have phagocyte. We have dermal cells that contain cells that have phagocytic action, so they can just engulf and destroy and get rid of some of those bacteria. And then lastly, psychosocial. That's a huge function of our skin as far as body image. So when we get to major burn injuries and some of those other skin conditions, that's a really big priority diagnosis, nursing diagnosis for these patients. Now getting back to this picture, as far as the heat regulation, again, the dermis is where this is happening, and this picture just shows you, if you look at the bottom right box, it says the blood vessels dilate. So increased flow to the skin results in more heat being delivered to the skin, and then greater loss from the body. So it just shows you that if we're dilating and there's more heat being delivered, then there is going to be greater heat loss, so that we can lower that body temperature. And then the opposite will be true on the left side of this picture when we have blood vessels vasoconstricting. So if we're cold or if we're applying ice packs, that's going to decrease skin blood flow and decrease skin temperature, and therefore the body will tell it to help to conserve body heat. Therefore, if we're cold, again, it's going to try to reduce that heat loss. Taking a health history for patients with skin conditions, is something that we do all the time. And again, regardless if they're being admitted for a problem with their skin, we're always doing 4 eyes on skin assessment to RNs that are checking skin, and we're asking appropriate questions related to their skin. Like I said, even if we are not working specifically in dermatology. So we're going to ask if they, for their own family and personal health history as far as skin allergies, allergies to foods, medications, chemicals, if they have certain sensitivities to cosmetics, soaps, lotions, and things like that. Specifically, we want information about the onset of their current problem as far as signs and symptoms, the specific location of their skin condition. Are they having pain with that, itching, or rash? And in your textbook, there's a nice nursing history table that goes through some of the medical, surgical history, family history, and questions that you could ask regarding the current health problem. We want a current list of medications and other medical conditions, as we always would. In particular, does the patient have chronic kidney disease? If so, we might be more apt to expect pruritus with that uremic toxins that are on the skin that can be that white powdery, but again, we want to know, do they have a history of psoriasis, or sensitivities or other actual diagnosed skin conditions. Nutrition is very important. What we put in our body also affects all of our body systems, and including our skin. So have they introduced any new foods or any dietary changes, and especially with that infant and young child age group, if they're having food allergies, this may show itself in different skin conditions. And then in skin exposure, when we are always assessing for risk factors, occupational risk factors, for example, or other risk factors for skin cancer, we always want to make sure we're doing preventative health teaching at the same time. So are they outside workers? Do they work construction, cement? Are they working along the highways doing highway maintenance? DNR workers that are out in boats and on lakes, what is their job again? And if so, what is, do they have protective clothing, hats, sunscreen, etc. That top of the ear is a really common area for skin cancer because, they might have a hat on but not protecting their earlobes. So what are the age-related changes in elderly? We'll have some pictures here coming up with many of them, but the cherry angiomas, you've probably seen kind of like a bright red mole. And this is just over time, the superficial blood vessels have been, violated or are not intact, so it forms kind of more of that bright red color. We definitely will recognize diminished hair, especially on the scalp and pubic area, lower legs. And again, some of the hair loss as far as baldness and things, especially for males, can be kind of passed along genetically. Dyschromia is the technical medical term for color variation. So we're going to see more color variations, and that can also be from excessive skin exposure over years, because that skin exposure is cumulative, but may see more freckles or dark spots or discolorations, or what we know as age spots. Neurodermatitis, or itchy spots, they definitely do have more dry skin as we age, and so may have patches of dryness or just more dry, itchy spots in general. Of course, the wrinkles, again, the photoaging damage from excessive skin exposure. There's increased loss of elasticity that helps produce that wrinkle or fine lines. Again, 90% of the wrinkling process is environmental and 10% is aging. So it's really what we put on our skin, what we use for skincare products, lotions, washes, and also skin exposure as far as sunscreen, etc. And then we already talked about excessive dryness, and then thinning of the skin as well. So definitely more of a chance to be cold. This is a picture of the cherry angiomas that we had talked about. In this picture on the anterior chest, you can see that area where it's a little more reddened, and this is one of those patches of excessive dryness. I think this picture shows many good things. You can see the decreased elasticity and the thinness and the transparency of the skin. We can see a big old nice vein that we'd like to start an IV on, but what it's actually showing is that liver spot, that darker age spot. So as far as the physical assessment, there are many things that we're looking at. Just in a general appearance, we can get a lot of information from our patients as far as the color, what their coloring looks like, the temperature of their skin, moisture, dryness, texture. Again, do we see any vascularity or lesions or bruising? You know, we know that skin turgor isn't accurate, but we can definitely check for that as a sign of dehydration. But more importantly, do they have really dry lips, cracked? Does their tongue look very dry? Those are all things that we should be looking for in addition to the obvious color and temperature of the skin. As far as erythema, this is the medical term for redness of the skin, and that is caused by congestion of capillaries or increased blood flow to that area. Now, in darker skinned individuals, erythema may present itself more as a purple gray tone, and so we want to make sure that we're able to assess skin color changes in both light and dark colored individuals as well. As far as a rash, you know, how do you assess a rash? Well, first of all, you want to make sure that you're wearing gloves. When we're assessing any sorts of skin conditions, we have no idea if they would be contagious or what exactly they are. So we want to make sure that we're wearing gloves. We also want to make sure that we're not having any facial expressions that show, you know, that we don't really like what we're seeing or that we're grossed out by that, because that isn't obviously professional, and patients will pick right up on that. So we'll have gloves on though, but one tip that I'd like to share on the rash is that if you can kind of stretch the skin and pull it tight or pull it taut, that will kind of make that rash stand out a little bit better. You'll better be able to see if the rash is raised, if there are clearly defined edges or not. Again, the best thing is to make sure you're taking a picture, but then also all of your wording to really work on being very objective in how you're describing it as far as the size, raised borders, etc. Cyanosis, we know that this is a late sign of hypoxia. Again, in dark skin individuals, it'll be more of a, instead of blue, it'll be more of like a grayish cast. We know that we can see it in the extremities, nail beds, lips, mucous membrane, so mouth, lips, the oral buccal, you know, inside of the cheeks, earlobes. Again, we don't want to wait for someone to be cyanotic, but if we do see that, we certainly know that they have been lacking oxygen for some time. Other color changes, the skin, we have hypopigmentation, which is decreased melanin, hyperpigmentation, which is increased melanin. Of course, different ethnicities and races will have either hypo or hyperpigmentation. Vitiligo is destruction of melanocytes in areas of the skin. So if you see patients with white patches, we call that vitiligo. Jaundice, we'll talk more about that in the GI unit, or we did talk about that, but that is where we have that yellow discoloration, and we'll see it best in the sclera and the mucous membranes. That indicates increased bilirubin in our blood and in our body. And again, I just encourage you to look. There's a table in your textbook that really goes through the color changes in both light and dark skin. You know, here in Brainerd, Minnesota, we don't have a lot of cultural variation, so we don't get a lot of good practice at that. So it's really important to you know, at least learn it from a textbook standpoint and be ready to assess a little differently. This is a picture of a rash. This was a rash on a child after antibiotic. So you can see it's pretty widespread. We know that antibiotic allergic reactions do start on the torso first. Again, if we pull that skin tight, we can better see. We'll be able to definitely see that it's raised, although you can pretty well see that it's raised as well just by looking at it. This slide is just reiterating that we can see best changes in hypoxia at the most distal points of our body, and that's where we check our cap refill. Again, remember, we can check cap refill not on the nails, but just on the tip of the toe there. That's going to be a great spot to do that, especially if they have thickened nails and peripheral vascular disease. And then, of course, really looking for jaundice, and not just looking, but actually pulling down, because you can see a lot of jaundice in the conjunctiva of that lower lid as well. This slide is just a summary of clinical findings and skin palpation. So what are we seeing when we palpate or touch the skin? Certainly we are palpating and kind of feeling for that third space fluid, that edema. You know, we can see it visually in many cases, but we definitely are still going to palpate, and we certainly need to push and see if it's pitting or non-pitting, and always be thinking about what is the cause of the fluid volume excess or the edema. Is it cardiovascular? Is it liver disease? Is it chronic kidney disease? Those are probably the three most common, unless they have chronic edema from some other lymphatic problem. Moisture, we certainly want to know if they have more moisture on the skin. Are they running a fever? Do they have hyperthyroidism or hypermetabolism? Are they anxious? Are they doing activity and they're sweating? If they have decreased moisture, of course, we're really thinking fluid loss, hypovolemia, dehydration. Also could be hypothyroidism, and could be just normal age-related changes. Again, as far as temperature, very obvious, but if we have increased temperature palpation of the skin, are they in some sort of a hypermetabolic state? Are they running a fever? Decreased temperature means we're not getting good cardiac output or good tissue perfusion, right? So we're thinking of all of the decreased cardiac output types of things. Are they hypovolemic? Are they in shock? Do they have sepsis, septic shock? And again, hypothyroidism. They can have decreased temperature control as well. They're usually very cold. Turgor, decreased turgor. Again, this is not super accurate, especially for elderly, where their elasticity is already decreased, but again, can show dehydration. And then texture of the skin, you know, this might be normal age-related changes. They might have had a lot of chronic skin exposure. If you take care of farmers, they typically are outside workers. They have thicker skin, but also there are some conditions like eczema that could show that thicker skin. So next up is wound assessments, and you have had your wound care information both in first semester or your LPN training, and then we did do a wound care week anyway in our lab class. So I encourage you to really review all of that, but then also you need to read this really good article, short article that summarizes. So not going to be talking about every single thing, but obviously it's very important to know the wound location and specific size. We measure in centimeters, length times width times depth. We need to know if it's a pressure ulcer or injury is the most technically correct, pressure injury. And again, it has to be on a pressure point in order for it to be considered a pressure injury. Otherwise, is it a surgical wound or is it a partial or full thickness? So those are kind of the three ways that we will describe or define what type of a wound that we have. And then the wound itself, if it's an open wound, we're going to have a wound bed or the base of that wound, and we need to know if there is necrotic tissue, which is non-viable or dead. And we have eschar, which is the black color necrotic tissue, but then you can also have slough, which is more of that yellowish color. And either way, they're both non-viable. They're going to both have to be debrided out of that wound bed or sloughed out of that wound bed, slough off out of that wound bed in order for new viable tissue to grow. Granulation is that pink, bumpy, healthy-looking tissue. Wound edges, we want to know what the wound edges look like. And again, if we have an incision, a surgical incision, we often document that the wound edges are well approximated, meaning that they are together, that they are closed. We don't see any open gaping areas of that surgical wound. Staples are intact or sutures are intact. We'll definitely talk about and document our wound drainage, our amount. And again, scant, small, moderate, large, and copious are kind of the words, but of course that's not super objective. There is some subjectivity on the part of the observer. So you can also do like a percentage of the dressing saturated, or the dressing had like a 50-cent size area, so you can kind of relate it to something that people would know. And then odor, is it malodorous? Is it purulent drainage, which is like pussy green yellow, which is definitely more indicative of an infection. Surrounding skin, what does the surrounding skin look like? Is it reddened? Is it warm to the touch? We want to know. Hopefully it's not, but those could be signs of infection. And then there's lots of different primary and secondary type lesions. Your book has charts on all of those. And again, if you're working in dermatology, you're going to get much uh, better at the actual what you call these things technically for the correctness or accuracy. But for our purposes, as most nurses working in like home care or long-term care or acute care, it's more looking at the skin and being able to identify if the skin is not intact, what is it, what type of a wound, size, color, and all that kind of stuff that we just talked about. Vascularity, we do need to obviously be up on our terminology as far as what does petechiae look like, those little red pinpoint dots. And again, if we have low platelets, which is our clotting factor, we would be more likely to have petechiae or those pinpoint bleeding underneath the skin. Ecchymosis is our term for bruising. And telangiectasis is basically, if you can think of like when it kind of looks like a spider, has like a little bit of a red, it's not a bruise and it's not petechiae, but then it has the little like thin spider type lines, that's telangiectasis. Turgor, we've talked about elasticity. Hair, if we're looking at hair and it's dry and brittle and real coarse, we really want to cue into either dehydration or malnutrition. And the nails, we talked about the thickness, especially with peripheral vascular disease and diabetes, where we have that chronic hypoxia. Clubbing, of course, is a sign of chronic hypoxia. And then if you see a bunch of pits or grooves in the nails, you want to think more malnutrition. So this is a picture of petechiae. And this shows several things, but I wanted you to look at the bottom left. If you have pits or grooves, either the Bowes lines or the pitting, we might consider more malnutrition. And then also that early and late clubbing, if you haven't seen actually what that looks like for the chronic hypoxia. Again, on the wound bed assessment itself, is it clean and granular, meaning it's granulation tissue, which is that pink, red, cobblestone, bumpy appearance. It could be clean but not granular. So again, it may not have granulation yet, but it's clean. Again, we talked about the necrotic, either the eschar or the slough, and you can see more of the definitions and descriptions of what that is. And then just a reminder to be very specific about like percentage of the wound that contains slough, or the percentage of the wound that might be eschar or granular. This is an actual wound bed where you could describe, again, we see some black or some eschar necrotic. We see some of the yellow slough. And then it's hard to tell in this picture, but I think we may see a few little small areas of granular. This is a picture of an open abdominal wound. If you haven't seen one, obviously the base of the wound bed we can't see because we have the packing or that dressing that's in there, the white, but at least you can see how far open a wound can be. And in this case, they're going to have to heal from the inside out. These patients would be great ideal candidates for a wound vac. You also want to make sure you're looking on wound beds like this for that tunneling or undermining, where we'll take a Q-tip because there very might be some tunnels or channels in this wound bed that are going deeper than what we can see. So we'll use the face of the clock, the head to be the 12 o'clock and their feet to be 6 o'clock, and we will document accordingly. So we already talked about wound drainage: scant, small, moderate, large, and copious. Different color. What are the correct terms for drainage? So sanguinous is the bloody. Serosanguinous is kind of the mixed yellow and blood. Serous is more of that clear yellow color. Purulent is more of a creamy, pussy yellow, green. It can be all different sorts of colors, beige, brownish, but it's definitely not serous, serosanguinous, or sanguinous. And then the foul odor, you just got to, as best you can, describe. It's malodorous, but if you can describe if it smells fecal or something like that, then you could actually describe it that way as well. We talked about making sure that you take a picture of the wound, but then also documenting based on the head of the person being 12 o'clock, the feet being 6 o'clock, and measuring in centimeters. Tunneling and undermining, so this is where we use that sterile Q-tip to measure the depth of the tunneling or undermining. I think the tunneling is the easiest for students to remember, and that's just an actual tunnel or sinus tract in a full thickness wound. So if you push the Q-tip, it's just a straight shot in one location. So you can see, for example, tunneling at 3 o'clock extends 3.4 centimeters. So you'll put that in, and then you'll kind of keep your thumb on the Q-tip where how deep it is, and then you'll put that right up next to a measuring tape to get that measurement. Undermining is where you can sweep, it's tissue destruction at the edge of the wound, and you can sweep your Q-tip all the way around. So it's sort of like a lip-like effect. It doesn't go just in one straight shot sinus tract. This is a nice review of what factors facilitate wound healing, and then we'll also talk about factors that, impair or delay wound healing. So usually, if we are young and healthy, we're more resilient to healing. Certainly, gentle handling and use of aseptic technique is very important to facilitate wound healing. Having good oxygenation and nutrients to the tissues and cells as far as blood supply, proper nutrition, protein especially, but other vitamins, and also would add there good glycemic control or good blood glucose control, super important as well. Again, proper oxygen level, early use of broad spectrum antibiotics. So for example, our pre-op antibiotics and the 3 that we do prophylaxis every 8 hours after surgery for that first 24 hours. Being healthy, having a healthy immune system as far as balanced rest activity and a strong immune system. And then certainly pain management and splinting the incision and making sure that we're not going to break anything open is also very important. Factors that interfere with or delay wound healing. Again, at this point in our education, you guys really know these things already, but it's really important to be able to identify those high-risk individuals that will heal slower or could possibly not heal, or take a long, long time to heal. So extremes of ages, of course, are less resilient. If we have any break in technique as far as sterility, there increases the risk of infection. Hemorrhaging or hypovolemia, any of that where they have decreased blood volume and decreased cardiac output, it's going to decrease the amount of oxygen and nutrients going to the tissues and cells and to our brain as well. Nutritional deficits, you certainly should be looking at everybody's albumin level or their total protein level to get a baseline of what they have, and we have some patients that come in very severely protein malnourished and low albumins. Again, remember albumin is 3.5 to 5, the same as potassium, so they come in like the 2s, and even I've seen people 1.8, 1.9. I mean, they're very, very malnourished, and they're going to have a hard time healing those wounds, especially if they have a big wound. Foreign bodies, of course, oxygen deficits, hypoxia, drainage accumulation. This one, if a wound is too moist, if there's too much drainage or too much moisture, healing cannot occur. That slows down healing. That's evidence-based and proven. That is why we really don't see wet to dry dressings anymore. Medications, corticosteroids, of course, are on the top of the list. They increase blood sugar, which interferes with healing. They mask infection. They basically impact veins and tissues, and as far as how much oxygen is getting there as well. And then systemic disorders. What are some chronic conditions that we keep our eyes out for? Diabetes, chronic kidney disease, any of the coronary artery disease, especially peripheral vascular disease, obesity, certainly at risk, higher risk for wound dehiscence, as well as delayed wound healing. And then wound stressors, you'll see wound stressors there, obesity again, that extra weight, vomiting, heavy coughing, straining, any of those sorts of things, not bending or lifting properly or lifting too much. Any of those things are very, very important, and we go through all of that with our discharge teaching. And then just simply overactivity and not allowing the wound time to heal. There are three major dressing classifications: wet dressings, moisture retentive or hydrocolloids, which is the most commonly used, and then occlusive dressings, like our tegaderms, like we use for sterile dressings for central lines. So again, we don't use wet dressings very often anymore because the wounds stay too wet and then they don't form the granulation tissue. So moisture retentive, there's many in that category, but they many times have three properties. They have the protection, obviously covering up the opened wound area. They also absorb drainage, which most of our wounds are going to have some amount of drainage coming. And then they also help with debridement. They have some internal properties in the dressing that help debride that tissue. Occlusive dressings, you'll primarily see that for like intact skin. Like you could put a tegaderm on intact skin of a heel that's real red and mushy. It's not broken down yet. It's like a stage 1, or an intact blister we could cover because we want to keep the blister intact. That is helping to protect that area. We can, and then you'll see the occlusive dressing. Again, occlusive meaning it's sealed on all 4 sides with our sterile central line dressing change. And they do have a new chlorhexidine dressing that has like a little chlorhexidine pad right in the center of like a tegaderm dressing, and that goes right over the top of that insertion site and proven to reduce infection in that area. And then as far as just again review your any of your handouts from lab, but then also review the article on wound assessment, Wound Care 101 article. So I'm not going to read this slide to you, but just know that we try to make sure that we're being cost effective with whatever wound care. As nurses, we need to do the initial assessment, take a picture, charting to the best of our ability, and then we need to do a referral to wound care and dietary to, get the experts involved with that. And then as far as dressing changes, it really varies depending on the type of wound, the type of dressing that we're using, and we will follow the wound care nurse's instructions. But a general rule of thumb is that 70% saturated, loose, or leaking. And then for any central line dressing, for example, that's you're not going to have drainage, it needs to be occlusive. So it's not sealed on all 4 sides. Well, then we need to do an immediate dressing change because that is supposed to be aseptic. One thing that I want to also mention here before moving on with all of this wound care is you need to be able to understand appropriate delegation and supervision. Typically, you have LPNs working in the long-term care setting where they will be doing the dressing changes and wound care, and maybe weekly an RN is doing a full assessment of that wound in progress and making sure everything is still appropriate. So just know your facility, where you're working, who is supposed to be doing what. As an RN in an acute care setting, we're pretty much doing all of the wound care for assessments, and there is some decision making typically needed with that as far as what type of a product to use. And then of course we have all of our RN wound care nurses that are certified in that area that are doing that. As far as UAPs, what you can delegate to the UAPs, not really anything with wound care per se, other than we can give them instructions on things to tell us or monitor if they see that a dressing has come off, or if there is a wound, an open area on the skin that they notice, well, then they need to report that for assessment by the LPN or the RN. As far as other focused assessments, again, we talked about cardiovascular status. We know that edema, somebody that has edema will be high risk for breaking open that skin. They can have so much edema that it'll break open that skin and it'll ooze, and you may have seen patients with that before. We want to look for those extreme weight loss patients that are very thin, less than ideal body weight, that have a lot of bony prominences that can break down and get red very, very easily. We know as a standard we turn and reposition every 2 hours, but there are many people that need to be repositioned much sooner than, and maybe even as frequent as every hour. So we need to really be watching for that. As far as cognition and mental status, we want to understand this in our patients, because patients who have dementia or who are not able to tell us if something hurts, if they feel pain or pressure on a skin area, if they feel or notice an open area. Again, patients with diabetes and neuropathy may not feel, so we need to identify those patients as well. Conditions of the skin, again, we're going to assess all areas of the skin. We will do 4 eyes on skin, 2 RNs on admission, and that is the latest evidence-based practice to make sure that we're not missing anything. And it's really important because if a patient has a hospital-acquired pressure injury. That is a big deal for the hospital ratings and cost and all of that. And so we need to know if they're coming in with it or not, so that we don't get dinged for actually causing the pressure injury or the skin alteration. Understanding all of the dressing care, skin care, dressing changes, all of that. And then again, we've talked about the nutritional status and really knowing our patients. Who has malnutrition? What types of conditions might we expect malnutrition? How about change in muscle mass and muscle wasting or recent weight loss? Or what about impaired swallowing and impaired oral intake? So as a nurse, we provide a very holistic assessment of all of these things. A quick review on the Braden scale. Again, in the acute care setting, we will be doing this on admission every 24 hours, once every 24 hours, and then if the condition changes. Typically in long-term care, it'll be on admission if their condition changes significantly, and then every 3 months when they do the full MDS assessment. So again, you need to know the different categories. You need to be able to identify and score patients using that tool. And then it's important, what I think would be more pertinent for NCLEX is they would either have a scenario with the tool that you can look at it, or it might be just a general statement saying, you know, you're caring for a patient that has a Braden scale assessment of 11. And would you know that 11 is bad? You know, so again, a higher number, 23 is a perfect score, 12 or less is very high risk. You do need to be knowledgeable about the stages of pressure injury, so you may need to refresh on this, but basically suspected deep tissue injury, the skin is intact, but may feel boggy, mushy, warmer. Stage 1, the skin is still intact. There is no blanching when pressed, and again, the tissue consistency can vary. It can be firm or it can be boggy, can have different changes in color variation. I mean, the biggest thing is stage 1 is the only stage where the skin is intact. So if the skin is not intact, you can automatically go to either 2, 3, 4 or unstageable. And again, I'll let you review those on your own. So this picture is just a nice review of the different pressure points. Of course, we're definitely paying great attention to the heels. For very thin people, the scapula and the coccyx area, but even the medial and lateral malleolus, again, if they're in any braces or musculoskeletal equipment, you know, we need to pay attention to those areas as well. Those immobilizer braces over the knees have some really hard bar type areas that we got to watch for. And then the other picture just showing the shearing and friction. Again, we know that head of the bed less than 30 degrees and even the knees up can really help with the positioning, because what happens is they slide down and they're shearing all the way, and then if we're not using adequate lifting or staff and actually lifting the sheet up and boosting them up in bed with proper technique, they are actually having friction and shearing on the way up as well. So make sure you're using adequate staff or using lift devices if necessary to prevent that. And again, I would just take a good review of the concept map that's in the book and all of the tables that go over just pretty obvious, fundamental, but good to review basics on skin prevention, skin health, what we can do to prevent skin injury. Nutrients important for wound healing. Again, we've talked about this quite a bit. You can review your wound care, but protein, very important to replace any body mass that may have been lost during a catabolic phase after stress. So catabolism, that's breaking down muscle for energy sources during stress times, is common, and so we need to make sure that we're replacing that. And we know that we need protein and calories and all of the various vitamins, iron, zinc, to replace those, but then also to facilitate wound healing. The other thing is iron, of course, iron and vitamin C for absorption of iron if there has been any blood loss related to the wound. For diagnostic evaluations of the skin, you know, we're not experts. If you're working in dermatology, you're going to be more familiar with this, but just briefly, skin biopsies, of course, this is where they actually biopsy scalpel skin incision, or they have like a punch biopsy instrument in dermatology where they'll take some sampling and send it off to pathology. Immunofluorescence is designed to identify a site of an immune reaction, and so this test combines an antigen or antibody with fluorochrome dye, and they can detect these autoantibodies with that dye. Patch testing you'll definitely see in allergen specialist clinics where they put a substance and then they identify patches of response, inflammatory response based on what is on the skin in that area. Skin scrapings, you'll most commonly see this to study microscopic skin scraping. So they might do a scraping under the nail and check for fungus. The Zonk smear is used to diagnose viral conditions, so blistering such as herpes zoster. And then clinical photographs. This is the very, very best way for us to get an idea of the wound itself and progress of the wound. We are now going to start the section where we talk about some of the dermatological problems. Overall, we have some main objectives for any patient with a dermatological or skin problem. Number one is to protect the skin. Of course, we want an intact epidermis. We want to prevent secondary infections. So a lot of these conditions, when we have a break in that barrier, there's just more chance of an infection developing. And then we want to reverse the inflammatory process. Again, most all of these conditions, the normal inflammatory response kicks in, and so we want to reduce that inflammatory process and suppress it so that the skin can heal. There is a general rule that will help with reversing the inflammatory process. It is if the skin is acutely inflamed, such as red hot, swollen, or oozing, we usually will apply wet dressings or more soothing lotions. And then for the chronic, scaly, dry conditions like psoriasis, it'd be more emulsions, creams, ointments, and pastes. As far as medical management, we'll talk about very specifically with each disorder what would be prescribed, but in general, we know that bath therapy is important. A big thing to always be thinking about with bath therapy, though, is safety as far as elderly and their ability. If it's slippery, obviously, but bath therapy especially can be helpful if there's a very large skin area that's affected, or we'll do foot soaks or hand soaks and things like that. So typically with balneal therapy, they say 20 to 30 minutes. They'll usually use bath oils or baking soda or something like that that will help to remove some of the dry crusts and scales. And bath therapy is also very helpful to reduce itching. As far as topical preparations and medications, we'll be doing plenty of teaching in our career on lotions, powders, gels, ointments, etc. And again, this is not just for the integument unit or the skin. Obviously, we're talking specifically about those here, but we need to know if patients are supposed to apply a thin layer, if there's areas that are contraindicated, etc. So as far as corticosteroids, we've covered that in the endocrine unit. So we understand all of the side effects of steroids, which you'll need to review. All of the systemic side effects do apply even with topical, and I think sometimes we don't think of the topical being as big of a problem, and they certainly aren't as much of a problem as, say, prednisone or IV solumedrol. As far as potencies, also we need to look at like the dose. We know that there's over-the-counter hydrocortisone cream that is 0.5 to 1%, and then there's a low potency that is a higher percentage, medium, and then, obviously all of those higher percentages have to be prescribed by the doctor. So very helpful to understand the potency of the topical ointment or steroid that you are applying. Are there any areas that are contraindicated? Of course, we never apply a concentrated topical steroid to the face, axilla, or groin. Much thinner layers of skin in those areas and absorb very quickly, so we would stay clear of those. How much should you apply? This particular topical medication is very sparingly. It needs to be a very, very thin layer, and they need to rub it in thoroughly. Not going to review the side effects of steroids because we just covered them very thoroughly, but again, everything can apply, especially if they're being used for long term. Most of the time, the topical steroids are not for long term, so it's not typically as much of an issue. And then systemic or oral or IV medications, this would be definitely more where even if they are on just short-term prednisone or steroids, you have like the Z-Packs that you'll see for people with skin conditions, or you see it sometimes with like bronchitis or airway type stuff going on. Antibiotics, antifungals, antihistamines for itching, analgesics, as far as acetaminophen, could be anti-inflammatories such as ibuprofen. So again, plenty of medications that could be options. The next two slides are just summary slides of the skin disorders that we're going to be covering, and I do have them separated for you so that you can learn them kind of in their category, such as, is it a bacterial type condition? Is it viral? Is it fungal? Is it parasitic? Those are really important to identify and put them in their category for treatment purposes, especially so that you can better understand what type of medication you would anticipate to be prescribed. Again, here's the second half of the skin disorders we will be talking about. We have separate slides on each of them, but just wanting to make sure that when you're learning them, you start to really understand where they fall as far as what is causing the skin condition.